today we're going to be going over an abdominal pain case. You don't have a ton of information about the case prior to this session. You have the case itself, but like the review materials before, I didn't give you that handout of what to study and all that, because abdominal pain can be pretty difficult and overwhelming because there's so many things that can be going on. And I want you guys to focus as much as you can on trying to be as logical with it to not overwhelm yourselves. And so I didn't want to give you all that information because I know some of you would be stressed out, and I don't want that. I don't want you to feel discouraged as you go through this. So the point of this case today is to go through it and go through how to think about these issues and think about the cases themselves, so that when you have the materials to review, you know what to think about and what to look for. Having said that, I am going to try to end by 12:05 if possible, because I have a graduation for my residency program that I have to get to. And so if you have more questions after the case, if we don't have time to get to it, I'll put out a survey or something in the classrooms to see if you guys want to talk about it a little bit more. And we can have like a session for like 20-30 minutes at some point when people are more available to talk about the case after you've had a time to think about it and think of questions. Okay, so let's get started. So we have a 56-year-old male with a 30-pack-year smoking history and hypertension who presents to the ER with worsening abdominal pain over the last 2 weeks. The pain is in the upper abdomen, and it feels like a pressure type pain with discomfort. And it's let's stop there. So Dr. Williams, so given his history of his smoking history and his hypertension, what are some things that you would be worried about?
Is that me?
Dr. Kristen Williams?
Oh, okay.
Is there another Williams?
No, my last name is Williams. It's okay.
Are you Kristen?
No.
Well, let's go with you.
All right, that's fine.
So what are you thinking of?
So I was sort of thinking, because he's kind of relatively older, kind of on the older end, and he's been smoking a lot, you want to look for liver issues and also lung issues, because that's mainly in the liver. And then also with hypertension, being aware of constriction of the vessels and things like that.
Yeah, so definitely the hypertension, you want to think about vascular constriction, you want to think about narrowing of the vessels. What are other things that smoking can cause? Like what are the big scary things that you think of?
Cirrhosis would be one.
Not with smoking. That would be more with drinking. What about smoking?
Like lung diseases and cancer.
COPD, lung cancer. Can smoking cause cancer in other places?
Yes.
Yes, it can. So that's something that you want to think about as well. And then smoking can also exacerbate like narrowing the vessels too. So good. All right, and so I say the pain is located in the upper abdomen. What is in that area? Like, what are you thinking about when I say upper abdominal pain?
I would think also like stomach and gallbladder and other things in the epigastric region. So like your kidneys maybe and your spleen.
Yeah, so stomach, you said gallbladder, kidneys kind of more in the back. Yeah, spleen, yes. What about the liver?
That also.
Yeah, the liver also. So all of those organs in that area, definitely. Pancreas as well. It's kind of in that epigastric type region. It kind of goes up and points towards the spleen. So yeah, the pancreas as well. Good job. Dr. Horder. So he states that it's difficult to eat because he gets full easily. What do you start thinking of with that?
I was starting to think about something in the GI tract in general, so either in the stomach or maybe a blockage in like the intestines.
Okay, and you're saying that because he's the food's not able to be passed down, and so that's why he's not really able to eat as much because it's just getting stuck.
That's what I was thinking, or he was saying he was feeling full very easily. So I was thinking that something to do with the GI tract.
Good. Yeah. So if you have something in the stomach that's kind of pushing into the stomach, or it's filling up that volume of the stomach, when you eat, you're gonna have less space to fill, so you're gonna get full more easily. So yeah, good job. What about the 20-pound weight loss over the last month? What are you thinking about there?
I guess that was pretty concerning because I'm thinking it's because he's not eating and maybe not getting enough nutrients. Because then he's also saying he's becoming fatigued and leading to like dizziness, not able to perform at work as well. So it's impacting his life in some way.
Yeah. So just going off of the weight loss specifically, if he's not eating as much, he's going to lose weight for sure. What if I told you he's eating perfectly fine, and he's eating everything he can? He's actually eating more than he usually he does, but he's still losing weight. What do you think of?
I'm not entirely sure.
Okay. What about with, like, let's say he has a smoking history, he has a cough with blood in it, and now he's losing weight. What would you think of?
Maybe cancer?
Yeah, cancer. So cancer can cause you to lose weight. Why?
Is it because the this tumor that is building and spreading is taking up like the nutrients that the body typically would?
Yeah, so cancer is a abnormal growth and quick spread of abnormal cells that are growing and dividing faster than they should. And so when you're growing and dividing, you need a lot of energy for that. And so with cancer, it's basically just sapping all that energy into the cancer itself, and there's not enough to go around for the rest of the body. And so a lot of times people will be will be eating normally and doing everything normally, but they'll still lose weight, and that can be a sign of cancer. What is one thing that you should ask him to determine whether or not that this may be cancer? And it's kind of a let me know what I'm thinking type question. So if you don't know, it's okay.
Maybe if this was like intentional, does he feel like he's actually eating more, or is he exercising? Is he trying to lose weight at this point?
Yeah, exactly. So if he's trying to lose weight, and that's intentional, then less likely cancer. But he's like, no, I'm doing everything like I normally was in the past, and I'm still losing weight. Then yeah, you have to think about cancer. Good job. All right. So Dr. Rios. So he's complaining of progressive fatigue, and he's not been able to keep up with his daily routine. He works as a construction worker, and it's been difficult to get through his day. He has to rest every hour. Why is that significant? Let's go with Dr. Sayani.
I'm not entirely too sure about that. Maybe because the pain is too much, he can't really bear it. It's kind of difficult for him to exert any sort of physical activity.
Maybe it's the pain, but he's not saying that it's pain that's bothering him. He's saying that fatigue is specifically what's bothering him. So, forgetting about what can possibly be causing the fatigue, why is it important to know about his fatigue? Like, what is it that he just said right now that was important? If you want me to repeat what he said, I can.
Well, he said he can keep up with his daily routine, so there's a change in that.
Yeah, so there's a change. There's a pretty significant change in his baseline, and he works as a construction worker, so that's a pretty physical job, right? And so if he has to rest every hour, that's a pretty big change from what he probably was doing before. So we know that this is pretty severely impacting his life, and that there's something very wrong going on. And it's not something like, a lot of times fatigue in the outpatient setting, if everything's normal, it can be depression or something like that. And so fatigue is one of the things that I hate evaluating and working up, just because it can be so hard to pinpoint what's going on. But with this patient, it's really affecting him, so that's going to be something that you need to pay attention to a bit more. He's also saying that he has significant dizziness when he gets up too quickly, which has made work more difficult. So what do you think about his dizziness?
Maybe it could be a result of like low blood pressure.
Yeah, so when we get up too quickly, do you know what happens?
Not really.
It's okay. So when we get up, as we get up, our blood pulls down to our feet. Why is that? What's acting on us that keeps us?
Oh, gravity.
Yeah, gravity. So gravity brings all of that blood down, and so if the blood's coming down to the legs, it's not going back up to the heart, right? So there's less blood flow to the heart, meaning the heart has less blood to push out to the rest of the body. So if you get up too quickly, have you ever gotten up too quickly and felt a little lightheaded?
Yeah.
Yeah. So it's that same thought where you get up too quickly, your blood pulls down, you have less return to the heart, you have less to push out. Now, why is it that we don't pass out when we do that?
Well, we probably have enough like blood sugars or something of that sort.
So our body is going to try to compensate, right? So when we our bodies want to maintain a certain amount of pressure because that pressure is going to be important to getting blood to our brains, and that's how we think that we survive, right? So it wants to maintain its cardiac output, how much blood is pushing out of the heart. And so cardiac output is a function of stroke volume and heart rate. Stroke volume just means how much blood your heart is able to pump out at any certain time. Heart rate is your heart rate, how fast it's beating. So if there's less volume going to the heart, it's going to want to compensate by increasing the stroke volume. So increasing the heart rate. So the heart rate goes up for this lower volume to push the same amount of output out. Does that make sense?
Yes.
Okay. So for him, if he's having this a lot of the time, it might mean that his body's having a harder time compensating, which means that his volume might be very, very low. For me and you, every time we get up, our hearts will start to compensate by beating faster, but we have enough volume, so eventually it'll get back to normal. He's having some pretty significant dizziness, so that's something to think about. Is his volume level too low? So with the volume level being too low, it might be something like dehydration, it might be a bleed, something along those lines. Does that make sense?
Yes.
Okay, perfect. All right, so Dr. Mariam, he's had ongoing back pain for the last 2 months, more notable in the left mid-back, and it's a deep ache, nothing's making it better. What do you think of with that history?
So with the deep ache, can you hear me? So with the deep ache, I was thinking that maybe it has something to do with his kidney, since it's on. You asked about his back, correct?
Yeah, his back.
So I was thinking that since it's on his back, maybe it has something to do with his kidney, and maybe he's having like a kidney disease or some kind of blockage there or something like that.
Yeah, so something maybe with the kidney. The kidney's kind of in that back area where the bottom of your rib cage is. So possibly something with the kidney. Now he's saying that he had blood in his urine not too long ago, which he attributed to a UTI because he had similar symptoms in the past, and so he drank cranberry juice for a possible brewing infection. So do UTIs cause blood in your urine?
Yeah, I think it is a UTI symptom to have blood in your urine.
Exactly. Yeah, it can. It can be a UTI. Does cranberry juice help?
I'm actually not sure about that.
It does for some people, and so I think I forget the actual mechanism of how it's proposed to actually help, but a lot of times our bodies can get rid of the minor UTIs themselves. So it's okay if he drinks cranberry juice.
Okay.
All right. So potentially a UTI. What else can cause blood in the urine?
I was thinking about kidney stones.
Maybe, yeah, definitely kidney stones can cause blood in the urine. Anything else?
And maybe if he, actually, I'm not sure of any other cause.
It's okay. So, okay, we'll table that for now. Okay, so let me just go through some of the comments. So somebody was asking about kidney stones, which we talked about. Someone saying kidney problems been getting worse the last 2 months, so definitely. Someone saying maybe stomach cancer, which that can also be a possibility. Someone was saying fatigue from the medications. So what do you think about his medications, Dr. Mariam?
I was thinking that okay, so his medication is for his blood pressure, and so when I looked into the side effects, some of them aligned with like dizziness and fatigue. So I was thinking maybe if he's like not taking them correctly, or maybe if like, depending on his dosage or something, maybe he's having like dizziness or tiredness from his medication.
Yeah, so if he's taking too much of his meds, he can be his blood pressure can get too low, and he can definitely have some dizziness. Good job. All right. So Dr. Justin. So he has no fevers, chills, night sweats, vomiting, bright red blood in the stool, constipation. Actually, sorry. Before we get to that, he has dark, sticky stools over the last week. What does that mean? Let's go with Dr. Isabel. What does it mean if he's having dark, sticky stools over the last week? Dr. Suhina?
I think that means that since it's dark, the blood is oxidized.
Okay, so how does that happen?
I know it has something to do with acid and
Okay.
combination of blood and acid.
So where is that going to happen?
In the stomach, I think.
Potentially, yeah. So in the stomach, in the upper GI section, right? So
Right.
So if it's mixing with acid from like the esophagus, from the stomach, or from the duodenum, it's that mixture of acid that causes a breakdown of the red blood cells and oxidation, causing it to be more kind of that darkish color. And so if it was blood that's going through the intestines into the rectum, it mixes with some of the stool, causes kind of a tarry, sticky black type of stool. But what if you vomit it? What does it look like?
I think that would be like the grainy, like the coffee ground texture.
Yeah, so it's coffee grounds. So it's kind of like it's like grainy. It literally looks like coffee grounds. So that can be an upper GI bleed that's coming up instead of going down. So good job. All right. Anything? So with the review system, so no fevers or chills. What does that tell you?
No fevers or chills, probably like no infection.
Yeah, probably not an infection. What about bright red blood in the stool? He denies that.
I think, is that a lower GI bleed if it's bright red?
Yeah, so it's most likely a lower GI bleed. Is there any time that you can have an upper GI bleed causing bright red blood?
I'm not sure.
Okay, so yeah, so you can, but that is a very fast and brisk bleed. So if you're just pumping blood into your stomach and it doesn't have time to sit and mix with the acid and it's just being pushed through because there's so much of it, you can have a brisk upper GI bleed, and that can be bright red blood, and that's super, super dangerous. That can basically at that point you need to probably go in and correct the lesion. So anything in like the small intestine that's just bleeding super quick, or in like the esophagus or the duodenum, it can cause bright red blood too. But yeah, good. All All right. So, anything else in the medical history you want to know about?
Maybe his personal history and the drinking
Okay.
and
Yeah. So
drinking and smoking.
yeah. So like the social history, he has a 30-pack year smoking history. He tried marijuana in college, tried cocaine, not really anything in the last 10 years. He's married, lives with his wife and kids. And so really the marijuana, the cocaine, it's a long time ago, probably not as important. What about the two to three beers a week? Is that too much?
No, but I think
Yeah, it's not that much. If he's drinking like that much every day, that might be too much. But yeah, Dr. Camila's asking, is he circumcised? Can that sometimes be related to chronic UTI? So it can not a chronic UTI per se. It can increase your risk of having UTIs if there is poor hygiene. So potentially. And yeah, sorry, I was referring to you when I called you by Dr. Isabel. I didn't know that was your middle name, so sorry about that. So, but we can go with you, Dr. Camila. Vitals, we'll go with the vitals. So the blood pressure is 110/66, heart rate is 110, respiratory rate is 16, temp is 99, and O2 sat is 96 on room air. What stands out to you?
Everything basically seems within normal limits. His heart rate, I guess, is a little bit elevated, but that can maybe be because his body's trying to compensate for like the fact that he's dizzy.
Okay, potentially. So yeah, you're right. So the heart rate is elevated. Everything else looks okay. What about the blood pressure?
Isn't that like basically within normal limits? Or
It
is
is.
like a little low?
It's around normal. But what does he have a history of?
Hypertension.
Okay. So if he has hypertension, what do you want to know?
We would expect a higher blood pressure, I guess.
Maybe because he's on medications, right?
Right.
So what do you want to know about his blood pressure?
Is this like I would look back in his history and see if this is usually what his blood pressure is every time he's coming into the
Exactly.
visits.
So you want to know what his baseline is, because if his
Right.
baseline is 140s systolic and he's now 110,
And this is low for him.
Exactly. So that's low for him. Versus if he's like 110 to 120, this is fine. And I think this was a little low for him. So good.
Okay.
So we're thinking what with his heart rate and low blood pressure.
It can be potentially like a circulatory problem because his body's
Yeah,
trying to compensate, like trying to push more blood.
Yeah, exactly. So his volume might be high or low.
Low.
Low. Good. So his volume's low. So we're trying to push more blood out. So good. What about in his physical exam? What do you want to know about?
Well, it says that he doesn't appear in any significant distress, so we know that it's not something that needs to, like, it's not like a stat problem per se.
Okay,
The fact that
good.
he appears underweight, that means it's like an obvious problem. Like, it's not just he's saying, oh, I used to be 180, now I'm 160. It's like he looks malnourished.
Yeah. Good.
The fact that he's tachycardic is consistent with the fact that his heart rate is elevated. And then I think the most important thing would be the fact that there's tenderness to the palpitation of the epigastric region and the CVA tenderness, which is kind of consistent with pancreatitis or like any pancreas-related pain or injury, maybe.
Okay. So,
But
okay.
what kind of, what kind of throws me off is the fact that there's no rebound or guarding.
Okay. So what is rebound or guarding?
Like when they touch you and you like flinch.
Yeah. So
Like to the pain.
how do we check rebound?
You like push deep pop,
We push deep, and then what do?
release.
We release. So we push down, we release, and as we release, there's like a wave of movement in the abdomen. And if there's tenderness there, what does that signify? When we release, if there's tenderness.
that there's like rebound.
Yeah, so good. So it tells us that there's something irritating that cavity, right? So there is something in that abdominal cavity that's not supposed to be there. So we
Right.
usually get rebound tenderness when there's like a perforation. So like if you start spilling stool contents into the abdomen, you're gonna have inflammation in the peritoneal cavity. So peritoneum and the things that line your intestines and your other organs have a lot of nerve fibers, and they can get irritated pretty quickly. And so if you have blood, you have stool, if you have infected fluid there, you're going to have rebound tenderness. And that's a sign that, something more dangerous is going on. What about guarding? What is that?
When you go to like palpate and they cover themselves because it's like too painful.
Yeah, so the muscles themselves are tensed up. So you push and it feels firm. And so that happens because you have inflammation in the area. So there's either voluntary or involuntary guarding. Voluntary guarding, it just hurts the patient kind of guarding themselves. Involuntary guarding is like you tell them to relax, it still feels firm, it feels like hard like a rock. That's a more ominous sign of something else going on. So really good job. All right. So no rebound, no guarding. Bowel sounds in all four quadrants tell us that there's good movement of the bowels. No suprapubic tenderness, probably not a UTI per se. Suprapubic tenderness is right above the pubic bone, and so if you push down and it's tender, a lot of times it's because the bladder is inflamed, and so that's a sign that the bladder's probably okay. All right, so. Let's go with Dr. Katie. So we say CVA tenderness is noted on the left. What does that mean?
It could mean that it could relate to like there's a problem with the kidney.
Okay. So what is CVA tenderness? What do we do?
I think you apply like a tapping pressure, right, to that area to see if there's like any pain.
Yeah.
See if there is a problem.
Yeah. So literally put my hand where that kidney is going to be, and I'm actually tapping pretty hard. And if they jump up because it's painful, that tells us there's inflammation of the kidney and potentially an infection, potentially a kidney stone. If there's irritation of the area or maybe like a musculoskeletal issue, they will have some tenderness there, but they won't be jumping up like with a kidney infection or something along those lines. For him, I think that he had some tenderness, but he wasn't really jumping up like that. So good. What about the cap refill of 3 seconds?
I think that's normal, with the normal range.
It is within the upper limits of normal. For me, that's a little prolonged. So I keep my suspicions high, and so with the cap refill of 3 seconds, let's say it is a little prolonged. What are you thinking of? What does that signify?
That maybe there's like a delay in like the pumping of the blood.
Yeah, so you're not perfusing the area as well. It can be a volume problem. It can be a stenosis problem where your arteries are stenosed and you can't really get blood flow to that area as well. So everything's a little bit delayed. But yeah, good. Anything else in the physical exam you want to get?
Maybe do like a rectal exam for the stool to check the stool.
Yeah, perfect. So you want to do a rectal exam. So what are you going to do for the rectal exam?
Get like the stool and check if there's any like bleeding from there, if there's like any possible infection or disease from it.
Yeah, so you literally get your finger, put it in the anus, and try to scoop as much stool out as you can. So you'll just stick your finger in and out will come stool. And so you'll wipe that on this little card, put some solution on it, and if it turns blue, there means that there's heme products there, that there's blood there. So for this patient, his rectal exam was positive for blood. So what does that tell you?
That probably like the kidney wasn't filtering the blood enough.
Would it be the, if we're doing a rectal exam, would it be the kidney?
No.
It just tells us that he has a bleed somewhere, right, in the GI
Yeah.
tract. Yeah, good job. So let's go with Dr. Halima. Any labs you want to get?
Yeah, so you would want to get a urinalysis just to see if there's anything going on up there.
Yeah, so we
So
get
you would want to, yeah,
Uh-huh.
sorry.
No, go for it.
Yeah, so you would want to also check his specific gravity to see if there's like a lot of solutes or not. And so that's going to tell you if the urine he's producing is diluted or not.
Perfect.
So-
So you're going to want to check the specific gravity to see if there's a lot of solutes in there.
Mm-hmm.
There's a lot of concentrated fat. So his 1.03, is that concentrated?
Yeah, it is a little concentrated, even though it's like within the normal range. It is still on the higher side.
Yeah,
So yeah,
So what does that mean?
it means that his urine is concentrated. So it's
So-
probably
Uh-huh.
a little dehydrated.
Good. So he's dehydrated. What about the
Mhm.
blood? He's positive for blood.
Yeah, so that probably indicates that there's some kidney issues or probably some injury to the kidney or maybe even the ureters.
Okay. So there's some part in that crack where there's blood being spilled. So I think someone in YouTube said, can it mean prostate cancer, which it definitely can. So yeah. But can this be a UTI?
I'm sorry.
Can it be a UTI, urinary tract infection?
No, I don't think so. Just
Why not?
because I think everything else looks normal. It's just only the blood. I think that's the issue here.
Yeah, and so I would probably get a UA. So this is just a dipstick, and so a UA would give us a little bit more information. But in the dipstick, there's no escalate, there's no nitrites. Those are both signs of infection. Doesn't really have it, so less likely. Yeah, good job. Brianna is asking could hemolysis be a cause of some of the circulatory concerns? It can. Hemolysis meaning that you're breaking up those red blood cells, and that can cause a low hemoglobin as well. So yes, it definitely can. All right, Dr. Halima, anything else you want to?
So his CR level is a little high, so
Which one?
probably something for that. CR and also BUN.
Yeah, so let's talk
that's
about
a
the BU
little
and
high.
creatinine. So the creatinine is above his baseline. So what does that tell us?
That he's probably producing a lot of like the end product of metabolism.
Okay.
I'm not really sure what, but
Yeah, in general, let's say like if your creatinine's high, what does that mean for you?
there's a lot of kidney function. I'm not sure.
Yeah,
Or
so
maybe problems.
there's a potential loss of function, meaning like there's a kidney injury, right?
Okay.
Yeah. So the creatinine is going higher, which means that there's a kidney injury. Good job. Let's go with Dr. Ahmad. With his creatinine being elevated to 1.8, what are the potential causes of kidney injury for this patient?
I would say that maybe if the UTI was not properly like fixed or something, or it like got a little too high or something, like that could increase kidney injury possibly. And he had when you touched on the back, it also jumped, or yeah, he had the CVA.
Yeah. So yeah, potentially if he had an old UTI that didn't get treated, he can have an infection causing a kidney injury for sure. But so do you remember how we categorize kidney injuries?
Renal, like pre-renal, and then like post-renal.
Yeah, so there's pre-renal, post-renal, and intrinsic renal. What do you think is going on in this patient? Which one of those?
Possibly like pre-renal, I would say, or maybe intrinsic. I don't think it's post-renal though, just because he didn't have any pain in his suprapubic tenderness or anything like that. Like he didn't have that.
Yeah, so potentially not post renal. So you're right. So it's probably pre renal. He's like Dr. Danny's saying, he's dehydrated, he's tachycardic, so his volume's probably down. He's not perfusing his kidney as well. So pre renal just means that you have a decreased flow going towards the kidney, and so the kidney's kind of starved with blood. It's not really filtering as much, so that causes kidney injury. Intrinsic renal, a lot of times we see it with medications or like contrast, and so intrinsic renal means something with the kidney itself that is going on, and then post renal, like you said, is some type of blockage for the most part. Mm-hmm. So someone like an elderly, like 78, 80-year-old guy with urinary frequency, and he's going to pee a lot. Has hesitancy where he can't really start the stream. A lot of times that's due to like BPH, so benign prostatic hypertrophy, where the prostate just enlarges and pinches on the outflow tract of the urine. And so that can cause an obstruction, causing kidney injury as well. But for this patient, we have signs of hypovolemia, low volume. And so that tells us that he's probably not perfusing the kidneys very well. So good job. What about the BUN?
It's high. It also points to a kidney injury or disease.
Yeah. So do you know about the ratio of 20 to 1 for the BUN to creatinine?
No, sorry.
It's okay. It's okay. I didn't expect you guys to. But so the BUN to creatinine ratio is a good way of seeing if somebody's like dehydrated or something like that. But the other really good thing about that ratio is it sometimes can point to a GI bleed. The BUN is a breakdown product, right? So when your red blood cells get broken up, it's blood, urea, and nitrogen. So that end product is released into the gut and gets reabsorbed into the blood. And so you can have an elevated BUN that is higher than what we would expect for the creatinine level. And so when the BUN is above, is 20 times more than the creatinine, basically, that can signal that there's some type of GI bleed going on. And so for this patient, they did have a BUN greater than 20 times the creatinine. So potentially a GI bleed going on. It's not 100%. You have to take it in context with everything else, but that is something that you should think about. So good job. So Dr. Mombeni, anything else you want to get in terms of labs?
Maybe like a CT.
Before we go to the CT, labs, like blood.
I'm not really sure what else I'd want to get.
So he has a GI. So it looks like he has a GI bleed, right? He has blood in his stool. So what would you want to do to check on that?
Maybe someone says maybe like a stool sample or like a.
So we got a stool sample when we did the finger test, when we did a rectal exam. What about just a general lab that we usually get on most people? We haven't talked about it yet.
Okay. I'm sorry, I really just don't know.
It's okay. Dr. Camila's helping you out.
CBC?
Yeah, just a CBC, just a regular old CBC. So we're going to get the complete blood count. So the white blood cells are 6,000, which is normal. Hemoglobin 7.2, and platelets 150. So what do you think is important in the CBC?
Maybe his like hemoglobin.
Yeah, is that a normal hemoglobin?
Is it like kind of low?
It's super low. Yeah, it's that's about the level where we would want to do what for this patient?
Maybe get him some extra blood, maybe like a transfusion or something.
Exactly. So we're gonna want to give him some blood. So we ended up giving him like 3 units of packed red blood cells. But yeah, good job. you had mentioned a CT scan. Why do you want to get a CT scan?
Well, maybe to check if like based on like his kidneys and other affected areas, see if we can get an imaging, see what's actually going on with his kidneys or any other organ in that area, see if there's maybe like a mass or something.
Yeah, good job. All right, so good job. So let's go with Dr. Stokes. Can you tell me what you think is going on in this patient?
My group and I thought kidney failure or possibly like an internal bleeding.
Okay, and why is that?
All of the labs were abnormal, and then like to add on to the CT, like to make sure nothing else was going on.
Potentially. So you're saying kidney failure. If we're talking kidney failure, why would he be pooping blood also?
That's where we were talking about, or we were thinking like bleeding within like possibly the GI tract because of the abnormal stool.
Okay, so he has both bleeding in the GI tract and the urine?
Oh, I was just talking about the GI tract, but
okay.
I'm not really sure about the urine.
Yeah, so we know he has blood in the urine, right? So he's bleeding from both sides. So
right.
Why?
Possibly like a tear. Or...
Maybe, but if we tear one, why would the other start bleeding? And I'm pushing you a lot more than I push everybody else. So I don't mean to be.
I'm not really sure, but possibly like not the. I can't remember the word. Like the like the opposite of like the diffusion, like.
Perfusion.
Or diffusion. Sorry.
Diffusion? What do you mean by diffusion?
It's like concentrated in one area.
Oh, so like, are you talking about like metastasis?
Yeah.
Yeah. So what are you thinking about with that?
Possibly cancer.
Cancer. Yeah. So something growing in there that grew in other places. Yeah. So when you have kind of different systems affected, you have a guy with some weight loss, you should think about cancer. Okay. So Dr. Roos, tell me what you want to get.
Well, I don't know if I thought about it the wrong way, but when I was going through it, I was leaning more towards like possibly a problem with the spleen that was then causing some of the other issues.
Maybe. You have it in that area, so yes, potentially. A splenic laceration or a splenic lesion wouldn't necessarily cause blood in the urine and blood in the stool, so less likely. But okay, so we're thinking that maybe there's some type of cancer. I think it was mentioned already. So what scan do you want to get?
A CT scan.
You can get a CT scan. Do you want to get it with contrast, without contrast?
Would you get it with contrast to see if there's a tumor like blocking anything?
Yeah, typically we would, but why can't we do contrast in this patient?
I'm not 100% sure.
Okay, that's okay. We had mentioned with intrinsic renal issues, what can cause an intrinsic renal kidney injury?
If the kidney's already injured.
If the kidney's already injured, and we give what?
I'm not sure. I'm sorry.
It's okay. Contrast, right? So contrast can injure the kidney. So if you already have an injured kidney and we give more contrast, well, you can cause that patient to go into kidney failure, right? So we never want to give contrast in anybody that has a kidney injury because it can exacerbate that kidney injury. Good job. So we're going to get a CT scan without contrast. And so the read of, so we got a CT chest, abdomen, pelvis without contrast, and it was limited because of the lack of contrast. But there was this 3 centimeter mass in the antral portion of the stomach. So that end portion of the stomach that goes towards the duodenum, that's where there was a mass. There was also a 5.5 centimeter irregular solid structure in the superior pole of the left kidney. So what are we thinking, Dr. Roos?
So it would probably definitely be a cancer.
Yeah.
And possibly if it's in a couple different places, we might want to think about it metastasizing. So because it's not staying in one place.
Yeah. So this looked like metastatic cancer. How do you know which one is primary? Which one is the original cancer?
Would it be which one is bigger because it's had more time to grow, or no?
Usually, yes. Usually you'll be right. Not all the time, though. But yeah, usually. Okay. So Dr. Mallon, I apologize if I mispronounced your name. What do you want to do next? And while you think about it, Dr. Camille is asking to repeat the CT scan results. So the CT showed it was limited due to lack of contrast. There was a 3 centimeter mass in the antral portion of the stomach and a 5.5 centimeter irregular solid structure in the superior pole of the left kidney. So, Dr. Mallon, what do you want to do next?
Is that me?
Yeah, if I mispronounced your name, how do you pronounce your name?
Mullen, but it's cool.
Mullen, sorry.
Yeah. No.
What do you want to do next?
I guess I would. Is there a possibility to like test for the masses?
So how do you want to do that?
Surgery.
To do what?
To remove the masses and send it to pathology.
So we want to send it to pathology, but we have multiple masses. So you want to cut off both of them?
Oh.
Because how do we know if there's any other masses anywhere else? And we're just kind of cutting into this person, right? Without really knowing. So first off, what do we want to do to categorize what this mass is? People in the chat are helping you out.
A biopsy.
A biopsy. So which one do you want to biopsy?
The one in the duodenum.
Why?
Or
in the stomach? Why?
Because I feel like that's higher up in the body, so it would be able to travel down to the kidney. Right there.
Yeah. So whenever we want to decide which one we want to biopsy, we're looking at which one's easier to get. And so the easiest one to get is going to be, you're right, it's going to be the stomach, because we're able to go down with an EGD. So we can get a scope down into the stomach and take a sample of that mass. And so, and that's what they did. So they saw an ulcerated mass in the antrum of the stomach with notable oozing. So it's oozing blood. A biopsy was taken and argon plasma coagulation was used for hemostasis. So they basically clotted off whatever was bleeding. And so, do you want to admit this patient to the hospital?
Yeah.
Okay. And how do you know when this patient's going to be able to go home?
I guess once they figure out what the sample was, and if they're like, it's like everything, like their blood levels and stuff sort of come back to normal, and they begin.
So it's whenever they're stable, right? So we're gonna want to wait till they're stable. We don't necessarily have to. We don't have to wait for the diagnosis of the cancer. If there is good follow-up, we can let them go home while we wait, because being in the hospital increases your risk for infections and other things. So we let this patient go home while we were waiting for the results, because they were stable. They got 3 units of packed red blood cells, and they didn't have anything else after that. And so, all right. So anybody can answer. What do you guys think the primary cancer was? Stomach or the kidney? Dr. Camila, you're saying kidney. Why?
So in his previous exams, it all points us towards some sort of kidney malfunction because of his increased 20-to-1 UN to CR thing. The fact that there's 2 different types of bleeds, like everything in the past had already been pointing us in the direction of the kidney, and not only that, the CT results tell us that there's an irregular structure in the kidney.
Yeah. So we saw both. We saw one in the kidney. We saw one in the stomach. The stomach seemed to be the one causing most of the problems because of the bleeding. But it was more likely the kidney because renal cell carcinoma, which is a cancer of the kidney, tends to go unnoticed for a long period of time, and because it really doesn't cause issues until it metastasizes or starts to affect the kidney function. We don't know if that previous episode of bleeding in the urine was from the cancer. It might have been a little less likely because we would have expected persistent blood in the urine, so it might have just been a UTI at that time. But the pathology came back as clear cell renal cell carcinoma, metastatic to the stomach. Patient was referred to hem-onc and started on monoclonal antibody therapy. He required multiple hospitalizations for the GI bleed and to control the bleeding from the abdominal mass, and required multiple transfusions. And so with this case, the renal cell carcinoma went unnoticed probably for a while until it was causing any symptoms. And so the big thing to remember about renal cell is that you're gonna see the effects of it later down the line, and smoking increases your risk of renal cell pretty tremendously. So was the GI bleed a result of the cancer? Yes, it was, because the cancer from the kidney metastasized to the stomach and caused that bleeding there. So with the mass that was in the stomach, it was starting to ooze and ulcerate, and you're starting to pump blood into the stomach, causing the GI bleed. Okay. I have to go to the graduation in the next 2-3 minutes, but if there's any last minute questions I can answer, if you guys want, we can talk about this case a little bit more once you have more time to think about it and gather your questions. We can have a short session at some point when people are available. And I'll send something out in the classrooms. Why doesn't cancer increase the white blood cell count? It can. It actually can. But it's not an acute inflammatory process as you would expect, like an autoimmune process or an infection. It is, and the way that I think of it is these are your own cells that are mutated. And so it would take your body to recognize that these are abnormal for you to actually have an immune response to it. But you can have a low level leukocytosis or elevated white count. Is it possible he has anemia? He definitely does have anemia. So his hemoglobin being low tells us that he's anemic, and we didn't get into the different types of anemia. That's something I did want to talk about, but we can talk about it in the future, or when we talk about this case a little bit more if you guys want. Why does contrast further damage a kidney that is in the intrinsic stage? So contrast, I forget the exact mechanism, but it can be, it's toxic to the kidney. So when you have a kidney injury already, your kidneys aren't able to really filter out that contrast, and you're not able to pee out as much, so you have more contrast there. I forget the exact mechanism of how contrast injures the kidney, so I can look that up and let you know. But because you're not able to filter as much, you're going to have more injury there potentially, and it can put you into kidney failure. Is it possible to get a CAT or PET scan? So the CAT scan is a CT scan. It's going to be with after, when we're trying to categorize what this mass is and what this cancer is, I would get a CT scan, but I would get it with contrast to better visualize the masses. A PET scan is helpful. It'll help light up where things have metastasized, but it's more useful when you're treating and you're trying to see if there's any recurrence of disease. PET scans can be pretty expensive as well. Hemolytic anemia is possible. We would get more labs to check if this is hemolytic anemia. The reason why we don't go down that path is because we have a good reason why he's bleeding already. So we have evidence of metastatic cancer and we know that he's bleeding in the stomach from the cancer. So we don't need to test for hemolytic anemia, but there are labs we can get for that. Can we take him off his ACE inhibitor, switch him to another medication just in case? He's also taking diuretic with it. Yeah, so that's a combination pill. We can definitely take him. I would take him off both of those medications and just probably put him on amlodipine. It's another type of blood pressure medication. Acutely during the bleed, I wouldn't have him on any medications because I don't want his blood pressure to go down too much. How do you determine if a patient needs chemoradiation? It all depends on the staging, depends on what the prognosis is, and it depends on what agents are available. Could diabetes be a reason for fatigue? Yes, it can. It all depends on what the level of your diabetes is, if you're uncontrolled or not. Okay, so I gotta go, guys. I hope you enjoyed this case. I hope you learned something from it, and seeing how we go through abdominal pain is a little bit more clear. You'll get another case in the next few days, and if you have any questions about this one, we can have another session for you. Take care and have a good day. Bye.